Good evening, everyone. Today we are going to have a great session on diabetology and insulin resistance and related issues. And let me introduce to you today's speaker. Dr. Ganavi Y.P is a qualified endocrinologist and a highly accomplished medical professional with a robust academic background and extensive experience in the field of endocrinology. Holding an MD in General Medicine from KLE University and a DM in Endocrinology from Ramaya Medical College, Dr. Ganavi has consistently demonstrated academic excellence throughout her educational journey. She has showcased her expertise through various research projects, publications, and presentations at national and international conferences. Dr. Ganavi's passion for teaching and training is evident from her roles as an assistant professor at Ramaya Medical College and her involvement in organizing numerous academic events. She has received several awards and accolades for her academic and research contributions, including a research grant from the Endocrine Society of India. Dr. Ganavi is dedicated to advancing the field of endocrinology and improving patient care through her commitment to excellence and continuous learning. So let us hear from Dr. Ganavi. Over to you, Dr. Ganavi.
Thank you, sir. Thank you for the kind introduction. Shall I start sharing my screen? So as we know, the incidence of diabetes is on the rise, and it has quickly become one of the most prevalent conditions, and it can be considered as a silent epidemic these days. So, a close link exists between diabetes and cardiovascular diseases, which both of it are the important cause of mortality and morbidity as well. So, cardiovascular risk factors such as obesity, hypertension, dyslipidemia are both common in both type 1 and diabetic individuals as well as in and therefore this basically poses a very high risk for cardiovascular events. In addition, many of the studies have found numerous biological mechanisms which have independently have associated the cardiovascular diseases with diabetic patients. Therefore, targeting the cardiovascular diseases in patients with diabetes is very, very important in order to minimize the long term cardiovascular complications of this disease. So, basically, this discussion where we will be reviewing the relationship between diabetes and cardiovascular diseases and the different mechanisms for the disease progression and also we will be discussing the current treatment recommendations and how we can mitigate this risk in the future to a much better extent will be discussed in this particular discussion. So we know that the prevalence of diabetes, as I said earlier, is on the rise, and this is data which is depicted prior. This was published in 2021, but we know that the latest Lancet article, which was published in 2023 in June by Shashank Joshi sir et al., has stated that at present there are about 101 billion people in India living with diabetes, and this prevalence is projected to increase to about 145 million by the end of 2045. And so the prevalence in India at present of diabetes is, though this study depicted that it is 9.6%, at present it is about 11.4%. And pre-diabetes also the prevalence is quite high, which is about 15.3%. Hypertension is about 35%. Obesity is 28.6%, and abdominal obesity, in fact, is about 39.5%. And even dyslipidemia has a high prevalence of about 81% as per this particular studies. So this indicates that there are multiple non-communicable diseases which are quite prevalent in the Indian setting, and it is also very shocking to see that 1 in 2 adults with diabetes are undiagnosed, and at present in the year 2021 in fact diabetes has resulted in about 747,000 deaths as well. So, and the number of people with diabetes in India is the second highest in the world. And as I said earlier, more than half of the people are living with diabetes who are undiagnosed. So, this indicates that there is a serious implication for the nation, and this definitely warrants urgent central as well as state policies and intervention to arrest this rapid rise in the silent epidemic. So now coming to cardiovascular diseases. So we know that diabetes definitely poses a high risk for cardiovascular complications, and hence the economic the burden both on the healthcare system as well as for the patient in terms of economic burden has definitely posed again a significant problem. So according to the IDF, the prevalence of coronary artery disease among diabetic patients is about 2.5%, and the studies have shown that more than 65% of the patients with diabetes die of these cardiovascular diseases, of which 80% are attributable to coronary artery disease itself. And the mortality which is seen after an acute coronary artery event is also quite high, especially in the Asian Indian setting, which is about 40%. So, so this indicates that there is definitely a very close link between diabetes and cardiovascular disease in resulting in both mortality and morbidity, and also hence the proper control and treatment of diabetes is very, very important in order to reduce the economic burden of the same. So hence mitigating this rising prevalence is very, very important. So coming now to the Framingham Heart Study. So we know that the Framingham Heart Study began in 1948, and it recruited more than 5,000 individuals, both men and women, between the age group of 30 to 62 years from the town of Framingham in Massachusetts. So they underwent extensive physical examination, as well as they underwent numerous interviews regarding their lifestyle, and then these data were later used to analyze their risk of cardiovascular disease development. So what we can see here in this particular slide is that when the single risk factors are present, that is, if there is obesity, smoking, dyslipidemia, presence of diabetes. So when these risk factors are present, and if they're present as a single risk factor, the odds ratio of developing the cardiovascular disease is quite less. But we can see here from the next panel, we can see that when there are 2 or 3 risk factors, the odds ratio of developing cardiovascular disease increases significantly. But when diabetes is in fact added as a risk factor, the risk of developing the cardiovascular diseases increases exponentially. We can see that the odds ratio of developing cardiovascular disease when the number of risk factors are 4, which includes diabetes, is about 9 times higher as compared to that of the single risk factors as well. So this again indicates that with the presence of diabetes, and in fact when there are numerous risk factors present, it definitely poses a significant health challenge. So also the second slide, we can see that basically this Framingham Heart Study, what they did was they compared non-diabetic and diabetic individuals. So in the first 20 years of the study, they found that about 6% of the women and 8% of the men developed diabetes, and the incidence of cardiovascular disease among diabetic men was twice as that of non-diabetic men, and in women the risk was much higher. In fact, it was 3 times more than that of the non-diabetic women. So again, we can see here from this panel that women aged between 30 to 64 years, the incidence of developing cardiovascular complications was much higher with the presence of diabetes as compared to that of the men as well. So now coming to the pathogenesis and the risk factors for cardiovascular disease and diabetes. So we know that the risk of cardiovascular disease and due to diabetes is due to multiple factors. It could be due to hyperglycemia, it could be due to insulin resistance, hyperinsulinemia, dyslipidemia, inflammation, oxidative stress, endothelial dysfunction, hypercoagulability, and even vascular calcification. Insulin resistance, both systemic and vascular, is associated with a high incidence of hypertension and dyslipidemia both. And this, with reduced glucose tolerance, definitely will increase the atherosclerotic process and hence the development of cardiovascular diseases. Also, in individuals with type 2 diabetes, insulin resistance is associated with the higher plasma-free fatty acid levels. This again leads to an increase in the production of glucose, and again there will be insulin resistance as well, which again leads to an increased triglyceride levels. So, this increased triglyceride levels induced by insulin resistance can be considered as an atherogenic dyslipidemia, which can again pose a risk factor for the development of cardiovascular diseases. Apart from this, there are numerous other inflammatory markers like the C-reactive protein, the interleukin 6 as well, which leads to a chronic inflammatory state, again, which can result in insulin resistance, and also it can result in beta cell apoptosis. So endothelial dysfunction also is one of the complications of insulin resistance, which we will be dealing later on, which can also result in platelet and leukocyte adhesion, can result in thrombosis and inflammation as well. So whenever there is elevated blood glucose, also the nitric oxide, which is a vasodilator molecule, also reduces. Again, this results in endothelial dysfunction. So all in together, there is the combined combination of hyperinsulinemia with hyperglycemia. All of this definitely poses a risk of thrombosis in a diabetic individuals. So also the calcification, the arterial calcification also increases because of the presence of advanced glycation end products. So together, all of these factors increases the contributes to the pathogenesis of atherosclerosis, and hence now rather than the glycemic glucocentric approach, it has moved. The management of diabetes has moved more to a cardiocentric and a renocentric approach in order to reduce these risks. So now coming to the pathogenesis of cardiovascular disease and diabetes. So it is more or less as from the previous slide. So we know that definitely the pathogenesis is quite complex. It is multifactorial, but we need to understand these profound mechanisms in order to adequately treat and modify the treatment regimes, and to have recommendations for preventing this devastating complication. So it could be the mechanisms could be either due to epigenetic changes, it could be due to intracellular metabolic changes. All of this leads to oxidative stress, low-grade inflammation, and endothelial dysfunction. So what are epigenetic changes? Basically, it is nothing but the interplay between the genes and the environment, which results in either the activation or repression of the gene transcription, which mainly involves the acetylation and methylation, which basically happens in the tail of the histones where the DNAs are trapped. So apart from this, the oxidative stress, where the reactive oxygen species are produced more, especially the vascular wall, can alter the mitosis, can result in increased apoptosis, can cause the endothelial cell hyperplasia, hypertrophy, can modify the extracellular matrix, and all of these again can result in the cardiovascular complications. Apart from that, as I said earlier, there are numerous inflammatory mediators like the TNF-alpha, IL-6, we have leptin, CRP as well, which are involved in these chronic inflammatory pathways within the vessel wall, which again results in the lipid accumulation and atherosclerosis and cardiovascular diseases. Basically, they cause the macrophages to get activated, because of which there is the atherosclerosis then eventually happens. So now coming to the prevention. So a focus on efforts to prevent cardiovascular diseases is a must in order to reduce the mortality and decrease the economic burden in our country. So cardiovascular diseases can be definitely prevented by controlling all the modifiable risk factors like the blood glucose, the blood pressure, the dyslipidemia, and also by changing our lifestyle in forms of stopping smoking, eating healthy, and increasing our physical activity. So the primary prevention basically involves the prevention or delay of the new cardiovascular events in patients with type 2 diabetes. So for this, early detection of the cardiovascular risk factors is very, very important in these high-risk individuals individuals and early diagnosis of also type 2 diabetes in subjects without cardiovascular diseases is also equally important for preventing this complication. So, secondary prevention, as we know, basically involves the treatment of risk factors in diabetic individuals who already had a established cardiovascular disease. So, for this, we need to move from more of a glucocentric approach to a more of a patient and an patient-centric approach. So, individualization of the treatment is very, very important, where the medication history, the lifestyle history, the cardiovascular, and the metabolic risk factors all should be considered. So, hence, a precision medicine in this particular setting plays a very important role in order to reduce the cardiovascular complications. So now coming to the therapeutic strategies. So we know that definitely early initiation of combination therapy. So we have the verified trial, which stated that definitely this leads to earlier glucose control, and it delays the deterioration of the glycemic control. Also because of this, the clinical inertia can also be reduced, and hence because of all these, there will be a better preservation of the beta cell function as well. So hence, initial combination therapy is definitely proposed to lead to a faster and a better glycemic control rather than the monotherapy, and definitely it reduces the clinical inertia with a better preservation of the beta cell function. So, at present, there are novel glucose lowering agents which can be used along with the lifestyle modification, which includes, apart from the metformin, we have the DPP4 inhibitors, which include sitagliptin, saxa, linagliptin, and allogliptin, the SGLT2 inhibitors like the canagliflozin, DAPA, and the EMPA, which are routinely used. And we also have the newer molecules like the GLP-1 analogs, like the liraglutide, gelaglutide, and also semaglutide as well, which regulate and restore the incretin function. So we know that the Asian Indian phenotype, as we know, is characterized by visceral adiposity with the lower metabolic tolerance and increased cardiorenal risk. So we need a personalized approach for such individuals, especially to target the multiple pathophysiological processes. So for this, again, early combination therapy of SGLT2 inhibitor with the DPP4 inhibitor definitely addresses this because it helps to mitigate the risk of hyperglycemia. It reduces hypoglycemia, the chances of developing hypoglycemia, and has a better metabolic profile in patients with diabetes. So especially this combination can be used for patients who have a higher risk of cardiovascular events and also the renal events as well. So and also because of the combination therapy, again the compliance improves and hence the clinical inertia also can be mitigated. So we know that the SGLT2 inhibitors basically cause glucosuria, because of which there will be an increase in the glucagon levels, which will be inhibited with the use of the DPP4 inhibitors. And also because of weight loss, there will also be an improvement in the beta cell sensitivity as well, because the adipose tissue in the beta cell also tends to decline, because of which there will be a better increased insulin the beta cell sensitivity improves. And also the because of the DPP4 inhibitors, it improves the insulin secretion, reduces the glucagon, which will be increased because of the SGLT2 inhibitors. And also because of all these factors, because of additional weight loss and the blood pressure reduction with SGLT2 inhibitors, and because of the weight neutrality of the DPP4 inhibitors, the combination has definitely come out as a very attractive option for the treatment of diabetic individuals. So it is safe, rapid, has a sustained glycemic control. It improves the insulin resistance, the beta cell function, reduces the body weight, reduces blood pressure, reduces the pill burden, and hence improves the compliance. And also it is supposed to be cost effective as well. So now coming to the cardiovascular benefits of the SGLT2 inhibitors, so we have the Declare TIMI study, which was in fact a very large trial, which included 17,000 plus population. In fact, in about 10,000 patients did not have the atherosclerotic cardiovascular disease. In this particular study, a population where SGLT2 inhibitors previously, the efficacy was previously lacking. So in this particular study, what they saw that was that in patients with type 2 diabetes who were at higher risk of atherosclerotic cardiovascular diseases, or those who did not even have atherosclerotic cardiovascular diseases, dapagliflozin definitely reduced the MACE, but it not reduced the MACE significantly, but it definitely reduced the risk of cardiovascular death or hospitalization for heart failure, which was in a significant proportion. So, and also the majority of the patients did not have a history of heart failure, and in this particular study, the prevention of heart failure what was stressed upon with this particular drug. So, hence, a new onset heart failure with the SGLT2 inhibitors can be prevented. So, this indicates that SGLT2 inhibitors definitely are a very good agents, and also a very promising agent for the prevention of cardiovascular diseases in individuals with diabetes. So, with that, I conclude my presentation, and we will be discussing the question answer session in the next section.
Thank you, Dr. Ganavi, for your insightful presentation on diabetes and cardiovascular disease. You nicely discussed the critical link between diabetes and cardiovascular disease, highlighting the impact of high blood sugar on heart health. It was amazing how how you also covered some preventive measures and also the treatment options. So please stay on with us for a discussion.
Yes, sir.
This
Yes,
is a complex and an important topic, and I'm sure there'll be many questions. So
yes, sir.
while I wait for the questions, maybe I start with the first question from myself. So, how
Yes.
do insulin resistance and endothelial dysfunction, which we think is at the core of the problem, interplay in the context of diabetes related cardiovascular complications? What is your take on that? Insulin resistance and endothelial dysfunction interplay.
So we know that insulin basically regulates the glucose homeostasis by the glucose disposal in the skeletal muscle in the adipose tissue, and it also inhibits the gluconeogenesis in the liver. So in addition to these classical functions of the insulin action, it also has other important effects on the blood vessels as well, apart from its effect on the heart, the beta cells as well. So the vascular endothelium, basically, insulin stimulates the production of nitric oxide, which increases the flow, and hence it results in an increased glucose uptake as well. So, whenever there is insulin resistance, so we know that the insulin signaling is quite the signaling pathway of insulin is quite complex, and it is dependent on the PI3K dependent signaling pathway. So, whenever there is insulin resistance, this PI3K pathway is also inhibited. So, because of which the nitric oxide production is also inhibited. So, whenever this nitric oxide production is not there, this results in the development of endothelial dysfunction. So, hence the presence of glucotoxicity, lipotoxicity, which also results in insulin resistance, and also inflammation, all the reactive oxygen species, inflammatory mediators, all of this results in the PI3K pathway inhibition of the insulin signaling, and hence results in endothelial dysfunction, and hence this results again in a cardiovascular disease state.
Thank you. That was a very nice answer to this complex question. So, another question is what are the distinctive features of atherosclerosis in individuals with diabetes? Is it different from normal atherosclerosis, and how does it impact cardiovascular risk?
So we know that individuals with diabetes, they do not manifest with all the typical symptoms and signs. So sometimes most of the individuals with diabetes, they may just present with tightness of chest or lower jaw pain or left shoulder pain, which are not typical, which are seen in a patient with the cardiovascular with the MI. So definitely type 2 diabetes, when it's present, it can result in silent MI as well. Apart from this, there are numerous other features of atherosclerosis which we can see in patients with cardiovascular diseases. So, which include the presence of intermittent claudication, which can be considered as a feature of peripheral vascular disease. Even erectile dysfunction itself can be considered as one of the atherosclerotic cardiovascular disease. Also, the presence of mesenteric ischemia in the form of severe pain following meals, weight loss, diarrhea can also be considered as an atherosclerotic feature. So, apart from this, on examination, if there is arcus senitis at a younger age, if there is frank sight, that is the diagonal earlobe crease, presence of xanthomas, presence of skin tags, presence of a carotid bruit, the renal artery bruit, all of these again suggest the atherosclerotic cardiovascular disease. Also, a patient who has had frequent TIAs, again, this indicates that there is a plaque building up in the carotids, which again can be considered as one of the atherosclerotic feature. Apart from this, a patient who has a sedentary lifestyle and with a strong family history of premature ASCVD, that is in a male less than 55 years or a female less than 65 years, if there is a family history of ASCVD, again can be considered as one of the risk factors for the development of atherosclerotic cardiovascular diseases. So, and also the presence of other inflammatory conditions like the presence of psoriasis or rheumatoid arthritis also can result in the increase in the inflammatory mediators, which again can be considered as a risk factor. So all of this features definitely suggest that a patient with diabetes, with if at all if the patient has high blood pressure, the presence of other metabolic syndrome features, dyslipidemia, all of these features point towards atherosclerotic cardiovascular diseases.
Thank you. So let us come to treatment options you discussed broadly. So how do these newer anti-diabetic medications such as SGLT2 inhibitors and GLP-1 receptor agonists influence cardiovascular outcomes in diabetic patients?
Definitely the newer medications like SGLT2 inhibitors and GLP-1 analogs have gained a lot of popularity these days because of their very promising data on the reduction of the 3-point, the 4-point MACE, the hospitalization for heart failure, and also the cardiovascular death. So, in fact, the SGLT2 inhibitors, some of the meta-analysis have stated that it reduces the risk of developing the MACE by about 11 to 15%, and in fact, heart failure by about 23%. And also, there is a decline in the renal disease progression as well by about 45%. So, and also SGLT2 inhibitors are known to reduce cardiac arrhythmias and also the atrial fibrillation and atrial flutter as well. So, at present, we have the canagliflozin, the DAPA, and the empagliflozin. All of these have proven benefit in reducing the hospitalization for heart failure in patients with reduced ejection fraction or with preserved ejection fraction. Though empagliflozin in the EMPA preserved trial did not show a reduction in MACE, but it reduced the risk of developing the hospitalization for heart failure. So the mechanisms include many with SGLT2 inhibitors. So one of it is the use of the ketones, because of which the reactive oxygen species, the production is reduced, and also it reduces the cardiac hypertrophy, the ischemia, reperfusion, injury. All of these are reduced, and there are numerous other mechanisms as well. That is preservation of the cell membrane integrity. So all of these mechanisms definitely have shown promising results in prevention of cardiovascular diseases in patients with diabetes. So, whereas coming to the GLP analogs, we have the numerous cardiovascular outcome trials with the GLP analogs. We have the LEADER, we have the SUSTAIN 6, we have the REWIND, the HARMONY, and also the AMPLITUDE studies, which have stated that all of these, in fact, are very good molecules in reducing the cardiovascular complications. So basically, they reduce the cardiovascular complications by numerous mechanisms again, which include one is mainly the weight reduction, and also they inhibit macrophage adhesion to the endothelium, reduces the oxidative stress, reduces the production of the advanced glycation in products, and also GLP-1 analogs, an added advantage is the reduction of the is that it increases the cerebral blood flow, especially in the middle cerebral artery, as depicted in the rodent studies. And in fact, have that is the reason the GLP-1 analogs also have a neuroprotective effect as well, and can be used in the mitigation of the risk of of cardiovascular complications in patients with diabetes. So, and also the newer molecule like the tirzepatide, there is the surpass CVOT trial which is ongoing, which will definitely will come out in a few months and will show us, and then in fact there will be evidence to state that the tirzepatide molecule also whether it will be hold a good promise in preventing the cardiovascular complications in patients with diabetes. Yeah. So that is about GLP-1 analogs and SGLT2 inhibitors.
Thank you. I'm a great fan of lifestyle modification. So, can you
Yes,
elaborate
sir.
on lifestyle interventions, including diet and exercise, in mitigating cardiovascular risk in individuals with diabetes?
Yes, sir. So whenever the blood pressure is more than 120 by 80, definitely lifestyle interventions should be considered, especially a DASH diet is what is prescribed for individuals with hypertension, where we need to restrict the sodium, we need to improve the potassium intake with the moderation of the alcohol intake, and even the patients should be emphasized about the smoking cessation and to improve their physical activity as well. So a 5 days aerobic activity per week is recommended, and also restricting the salt intake to about 2.3 grams earlier is what is recommended. And also a Mediterranean diet can also be used where where there is a restriction of saturated and also trans fat with the increase in the use of the omega-3 fatty acids, the use of increased fiber, the use of plant sterols is also what is recommended in order to reduce the risk of dyslipidemia, causing atherosclerotic cardiovascular disease in patients with diabetes. So that is about the lifestyle modifications is what recommended, sir.
See, there have been a lot of advances in cardiovascular management of diabetic patients, but we still have challenges in primary care setting. So, what are the challenges you see and opportunities in implementing comprehensive cardiovascular risk assessment and management in diabetic patients within primary care setting?
So, especially in the rural setting, we know that though we have a lot of comprehensive interventions, and also there is multiple, and also because the cost of the treatment has also declined significantly. But in a primary care setting, especially in rural India, there are multiple gaps in in the implementation of these interventions. So the most important challenge include the patients who have a very high consumption of carbohydrates, fat, very low intake of fiber, decreased physical activity, tobacco consumption, not having adequate glycemic control, poor hypertension control with the dyslipidemia. So all of these definitely pose a significant challenge. So in primary care practice, especially in rural India, we need trained individuals who will be able to recognize these risk factors, educate the patients about the same, and implement primary prevention and the secondary prevention strategies as well. So people with type 2 diabetes from the rural India, we need to create awareness regarding the cardiovascular diseases, regarding the prevention of diabetes itself, regarding the prevention of obesity, especially in the adolescent age group, in order to prevent this rising epidemics.
Right. Now, there is a close link between kidney disease and cardiovascular morbidity and mortality. So, could you explain to us how does this diabetic nephropathy contribute to cardiovascular morbidity and mortality, and what are the implications for clinical management?
So we know that in the recent years there are a number of studies which have shown that patients with CKD have developed cardiovascular diseases as well. So in fact, it has been stated that death due to cardiovascular events is the most common cause of death in patients patients with end-stage renal disease as well. So, and in fact, the risk of death is more than 10 times the higher in patients with CKD stages of about 3 to 4 times, stages 3 to 4, the CKD stage 3 to 4. So, so all of this definitely poses a very the presence of CKD itself poses a very high risk for cardiovascular death. So, cardiovascular complications can vary widely in patients with CKD. They can vary from presenting with heart failure to presence of coronary artery disease. Even peripheral arterial disease is also quite common. Even sudden cardiac death has also been seen with patients with CKD. So, although there are optimal strategies for the prevention, diagnosis, and management of these, we need to address all the common pathophysiological processes that include the hypertension, the elevated blood glucose, dyslipidemia, in order to have in order to prevent the development of the cardiovascular diseases in patients with CKD. So, related to the management of hypertension and albuminuria, so we know that albuminuria itself can result in the inflammatory mediators to go high, which can again result in the development of cardiovascular complications. So, so mitigating this hypertension and albuminuria, especially patients with CKD, can go a long way in reducing the cardiovascular complications. So we can use the ARBs, the ACE inhibitors, basically the RAS inhibitors, and also we have the SGLT2 inhibitors as well, which help in constricting the afferent arterioles. So all of these mechanisms, all of these drugs, in fact, can be used in patients with type 2 diabetes in order to reduce the cardiovascular complications. The RAS inhibitors, the SGLT2 inhibitors will definitely help in reducing albuminuria and also the hypertension and hence the risk of cardiovascular complications in patients with CKD, sir.
Right, thank you. So these days, people are now increasingly using these biomarkers. So, what are the emerging biomarkers or imaging modalities for early detection and risk stratification of CVD in diabetic individuals? Your take on that?
Yes, sir. So we have novel biomarkers like we have the HSCRP, we have the galactin-3, we have the B-type natriuretic peptide, we have the N-terminal pro-B-type natriuretic peptide as well. Then we have myeloperoxidase, the fatty acid binding protein, and the C-reactive protein, the risk of developing heart disease and in providing the prognostic data. But given the complexity of this cardiac illnesses, these multiple markers are not can be used, especially the ones which are used routinely used include the HSCRP, the troponin I, the BNP. So these are the ones which are clinically used. Though the other markers are still in the research, definitely they can be used for improving the risk stratification, for improving the diagnostic accuracy, and also the care of these cardiac patients as well. So now coming to the imaging modality, so we know that echo plays a very important role in detection of the subclinical dysfunction. So we have the left ventricular dysfunction, which is very much seen in patients with diabetes. So it can be either a systolic, a diastolic dysfunction, or it can be a mixed phenotype as well. So, so diagnosing this is also very important. So, apart from the echocardiography, there have been advancement in the CT as well, the CT imaging. So, we have the CT angio, then we have the coronary artery calcium score, even we have the MR spectroscopy, and also the myocardial computed tomography perfusion as well, and also the stress myocardial perfusion scintigraphy, and also the cardiac MRI as well, which will help in diagnosing both the ischemic, the non-ischemic cardiomyopathy. So we can also know we have the numerous nuclear medicine. Sorry, we have numerous other markers as well. We have with the help of the nuclear medicine physicians, we can also use the stress myocardial perfusion scintigraphy as well. So to see whether there is hemodynamically significant coronary artery disease. So all of these newer imaging modalities definitely hold the promise.
Nice, thank you. So there is one more question. You see, we have moved from glucose-centric approach to cardiovascular centric or CVD centric approach. But still, glycemic control is very important. So, can you enumerate the strategies that can be employed to optimize glycemic control while minimizing the risk of hypoglycemia in diabetic patients with established CVD?
We know that we had the Advance, the Accord, and also the VATT trials, which were done, which stated that a very stringent glycemic control, especially in a patient with long-standing diabetes, those who have established cardiovascular diseases. In those individuals, in fact, it did not reduce the risk of the cardiovascular death. In fact, there was slightly a higher risk of developing cardiovascular death. This indicates that a very tight, stringent control will be beneficial in individuals who have a shorter duration of diabetes, who are young as well. So, a very tight control in elderly individuals with long-standing diabetes, those who have established cardiovascular, well established renal complications because of diabetes, might not be good. So, in those individuals, relaxing the glycemic target is a much better approach rather than going for a very tight glycemic control. So, in those individuals, we can use numerous the oral anti-diabetic drugs like the biguanides, that is the metformin. Then we have the DPP-4 inhibitors, we have GLP-1 analogs, we can use alpha glucosidase inhibitors as well. And also the SGLT2 inhibitors, the mainly, which basically do not increase the insulin directly and will act in a glucose independent manner. Whereas we know sulfonylureas, especially the lipidamide, which has now, which in fact can inhibit the ischemic preconditioning, should never be used in individuals with type 2 diabetes with established cardiovascular diseases. So, avoiding sulfonylureas in individuals who have long-standing diabetes with established cardiovascular disease and use of other agents will be helpful. In apart from that, whenever the patient is using insulin, it is always better to go for, if at all, if the oral intake of the patient is less, then always it is better to go for a basal bolus regime rather than going on for a premixed regime. So the fine tuning of the dose can be made with the basal bolus regime. But if the intake is very poor in such individuals, just a basal insulin is more than sufficient. So, by using these steps, that is, rather than using sulfonylureas, using the analogs, the rapid acting analogs, or even the ultra rapid acting analogs can be used in order to reduce the hypoglycemia risk. And these analogs, the added advantages sometimes can be given after meals if the oral intake is poor. And also, using just a basal insulin in individuals with a poor oral intake can also just be more than sufficient in order to reduce the glycemic burden.
Now, let us move on to socio-economic disparities. What is your take on this? How do the socio-economic factors and health disparities influence the intersection between diabetes and CVD? And what strategies can be implemented to address these disparities within healthcare system? You know, ours is a very diverse place. We have a lot of these socio-economic factors and health disparities in our system.
Yes. So definitely, though we know that cardiovascular disease and diabetes is a major and a growing problem, less attention has been paid to the management of this particular condition in between the different socioeconomic strata. So, there are a number of factors which have an inverse relationship between the socioeconomic status and the occurrence of cardiovascular diseases. So, in addition to the socioeconomic factors such as the employment and the income, which also affect the death, other lifestyle factors can also pose a very important role. So the lower socioeconomic strata group, especially after an insult, will face more health consequences in the long run. So, definitely, all it has been well established that the difference in the socioeconomic strata, the reducing the and in fact implementing a better health strategy in both the strata of the population is very very important in order to reduce the chronic disease burden in our country. And for this, we need to have community health workers, and also the social risk assessments, and also the behavior counseling, which can reduce the and also which can and we can and we need to have strategies where we need to educate patients about the reducing the blood pressure, the blood sugars, the dyslipidemia. All of these definitely will be helpful for reducing the disparity between the two strata of the population. So, all in all, community-based research approach, if there is a research activity which can be taken up, which will identify the different challenges between the two groups, and also which and implementing strategies to address the same can definitely be helpful. So we have to integrate the community-based approaches to our society where we can reduce this disparity.
Thank you. Just one last question, okay?
Yes, sir.
So, because ultimately it comes down to patient education and awareness. Unless we have that awareness in our patients, in our population, we are not going to get all these benefits that you have been talking about, the advances in cardiovascular disease and diabetes. So, what strategies can enhance the patient education and awareness regarding the link between diabetes and cardiovascular disease in primary care setting? The last question, I promise.
Yeah. Yes. So in the we should have a multidisciplinary approach for the same, where we can educate the patient, where we can empower different strategies, where there are different stakeholders available who have active engagement for educating the patients about the risk factors and also to reduce this cardiovascular risk. So I feel patient education is the most important foundation which we can build upon in order to reduce the complexities which are associated with diabetes as well. So for this, the healthcare professionals play a very important role, especially in the community setting. The community healthcare workers play a very important role. So, so patients need to be educated about the strong link which is present between diabetes and cardiovascular diseases, and the healthcare providers should educate them not only about glycemic control, but also they should educate them about the other lifestyle modifications as well. So, also empowering this patients with this knowledge, the skills necessary for this preventive strategies will have onus on the, like, they will have a responsibility on their health as well. So it should be an informed, along with that, the healthcare professionals should have an informed decision making when you're counseling the patients. That is, the patient should be educated about the different treatment options available. So they should be allowed to choose about the different pharmacological agents which are available, and hence they should be empowered to make their own choices. Along with this, the self management should also be about, so the practical skills about monitoring the blood glucose on their own, about adjusting the dose of insulin according to their own, recognizing the symptoms of hypo and hypoglycemia, and also they should be enabled to modify their carbohydrate intake as well, and the adjustment of the insulin dose as per the carbohydrate intake again should be told to the patient. And along with that, the modification of the risk factors like the lifestyle, that is smoking cessation, the stress management, the physical activity, the dietary changes should be educated to the patient. So, all in all, using a digital therapeutics for the same can also be done. So it should be a multidisciplinary approach where the patients are educated, empowered, they have their own skills of decision making, and then with this knowledge, they will be a partner in the journey towards a better health. So by embracing the model of multidisciplinary care, definitely the management of cardiovascular health in patients with diabetes can be done much better.
Thank you again, Dr. Janavi, for sharing your expertise and for staying us with for the discussion. Were some wonderful questions and you answered them nicely. This has been, of course, a very,
Thank
very
you.
informative session, except for a few technical glitches, which we always get in such kind of online programs. I would also like to thank all of you in the audience for your participation, the questions and the insights you shared. They were, of course, valuable. So, before I close this, I would just like to summarize the key takeaways that we covered a lot of ground today discussing the connection between this diabetes and cardiovascular disease, the pathogenesis, the clinical implications, the potential risks, and also covered some diverse areas like socioeconomic disparities, diabetes, health education, and hopefully some steps towards prevention and management also. So, with this, I hand over back the mic to the organizers. Thank you, John V. Thank you, everyone who has been here as part of this session.